so it's not a topic that we normally teach as a subject. Because chronic disease, I mean, Macrocytic anemias are caused mainly by chronic disease, hemolytic anemias, which you will be covering as you continue with your coursework. So today we just talk about macrocytic anemias, and basically macrocytic anemias, as you know, it's a morphological classification, where we say there's the size is above 96 femtoliters. Remember, the normal size is between 76 to 96. Below 96, 76 is microcytic. Above 96 is macrocytic. In between is normocytic. Or if there's a mixture of both macro and micro, you might have a picture of normocytic and normochromic, but that's what we call dimorphic picture. Is another classification. So we normally have microcytic, normocytic, macrocytic, and dimorphic picture. But today we should be talking about macrocytic anemias. And so macrocytic anemias, depending on the etiology, can be divided into two broad classifications. You have the megaloblastic type and the non-megaloblastic type, depending on the cause. Next slide. So let's when you talk about megaloblastic, what does megaloblastic means? Megaloblastic refers to the type of cell that is found in the bone marrow when you have certain conditions associated with the macrocytic anemias. So this anemia is an anemia in which DNA synthesis is impaired with delayed nuclear maturation. So this leads to what we call megaloblasts, which are basically large cells which have a large immature nuclei, and this what we call cellular gigantism. So they are basically large cells. The main causes of megaloblastic anemia are the B12 and the folates. Their main role in the body is to make DNA. So when they're making that DNA, because they are lacking or they are not there, you end up having an impaired formation of the nuclear where the DNA is contained. So megaloblastic changes occur in one, vitamin B12 deficiency or any abnormality of vitamin B12. So this includes absorption problems, for example, in pernicious anemia, where you have intrinsic factor deficiency, because intrinsic factor deficiency factor is important for the absorption of vitamin B12. So you have the vitamin B12, yes, but you're not able to absorb it, so you don't get it in the body. The other cause of megaloblastic anemia is folic acid deficiency, but again, abnormal folic metabolism for any reason. I think we'll be talking about that. And finally, any congenital enzyme deficiencies in DNA synthesis or drugs that interfere with the DNA synthesis, e.g. hydroxyurea, azathioprine, methotrexate. Yeah, those are drugs that interfere with the DNA synthesis. So they interfere with the DNA for formation of all cells, including the red cells. So you result into megaloblastic anemia. Next slide. So what are the mathematical values we find in macrocytic anemias? MCV of more than 96 femtoliters, we've said that already. The peripheral film will show macrocytes. Those are big cells, more than 96, with hypersegmented polymorphs or neutrophils. Which have 6 or more lobes in the nucleus. The normal lobes are between 3 and 4. But in megaloblastic anemia, these neutrophils will be hypersegmented, having more than 6 or more lobes in the nucleus. And if Megaloblastics is severe because, as we said, it impairs the DNA formation. You'll have leukopenia and thrombocytopenia as an accompanying consequence. Next slide. So we start with the vitamin B12. Just talk about it briefly. Then B12 is also called cobalamin. Yeah, cobalamin, and it has many names. The one name is cyanocobalamin. It's also called nitrocobalamin, hydroxycobalamin. There are all those types of vitamins. The names that are used when you go to the books. And it's a complex. And B12 is normally a complex. It's a B12 complex. So it has very many, but we all call them cobalamins. So the sources of the cobalamins in B12 is mainly meat products. Yeah, meat products, but not plants. Yeah, it's mainly from meat, fish, eggs, milk. Yeah, animal products. The daily requirement is about 1 to 2 milligrams per day. It is stored in adults. We have 2 to 3 milligrams in the liver. That's why it's stored. And luckily for it, it may take up to 2 years or more before the B12 deficiency. As the daily doses are very minimal. So the half-life is up to 1 year, meaning that if you stop eating meat products, you can stay for a whole year without any having symptoms of vitamin B12 deficiency. Next slide. So B12 is absorbed in the stomach. So once it reaches the stomach, it's bound by intrinsic factor. So once you eat it, once it's ingested into the GI system, once in the stomach, the parietal cells, which are found in the stomach, release intrinsic factor, which then binds to vitamin B12. And then these together are absorbed in the terminal ileum. Once in the terminal ileum, the combination is transported by transcobalamin 1 or 2 and 3. There are different types of proteins. Those are transport proteins. It was transported then to the liver for storage, and some to form now the bone marrow. That's why we said above that if you don't have intrinsic factor, then you may not be able to absorb the vitamin B12, and that's one of the causes of megaloblastic anemias. So B12, essentially, as we said, is important for DNA formation. That's the main role of B12. Yeah. And the process is essential for the hematopoiesis, that is production of the red cells, of the white cells, of the platelets. That's why when you don't have it, you have leukopenia, you have neutropenia. You have leukopenia, you have thrombocytopenia, and you have megaloblast or anemia. And then it's also important for formation of myelin of nervous cells. Those are the main functions of clinically that are important for B12. Next slide. So what causes vitamin B12 deficiency? What will make you have a B12 deficiency? Could be because you're not taking the food. You're not taking any food intake. People, poor socioeconomic status, vegetarians, alcoholics, yeah, those may have not take or poor absorption, not eating well, or decreased absorption. Decreased absorption, basically, when you don't have decreased intrinsic, when you have decreased intrinsic factors, is the commonest cause. As we call that pernicious anemia. Yeah, when you have decreased intrinsic or lack of intrinsic factor, that's referred as to pernicious anemia. You have total or partial gastrectomy because now you don't have the stomach to produce the intrinsic factor for you now to be able to absorb the vitamin B12. Atrophic gastritis, gastric cancer, Yeah, those are things that are affecting the stomach, or the ileum, yeah, where the absorption is done, the jejunum where the absorption is done, or manifestation by fish tapeworm, Developodium latum. That's not common in our setup. It's more of the Asian countries, but it's something you need to be aware about. Somebody with ileal disease, because that's where the vitamin B12 is absorbed. So these are some of the causes of vitamin B12 deficiency. Next slide. Pernicious anemia, we also call it Addisonian anemia. It's basically defined as a condition in which there is atrophy of the gastric mucosa with consequent failure of intrinsic factor production. This affects B12 absorption. That is one of the causes. But you can also have where you have antibodies that are formed against intrinsic factor, meaning that they're being produced, yes, but the antibodies that are binding to it, so it's not able to bind to vitamin B12. So those are the two causes of pernicious anemia. One is atrophy of the gastric mucosa, where the parietal cells produce the intrinsic factor. When you do not have that, you have now pernicious anemia. Or you have antibodies. The parietal cells are producing the intrinsic factor normally, but the antibodies which are binding to the intrinsic factor, therefore preventing it being bound to B12. Next slide. As you already, B12 is important for, we talk about so both B12, vitamin B12 and folic acid are essential for DNA synthesis and maturation. You've said that already. In case, just repeating, in cases of megaloblastic anemia, there is a deficiency in DNA synthesis. So the rate of cell division of many cells in the body is affected. The most affected cells are those with rapid rate of division and growth. Examples include hematopoietic cells, the gastric mucosa, and of course the nervous cells, especially in children. So that's a pathophysiology of how the B12 and folic affect the red cells. Next slide. So we've said this, I think just to repeat, to say megaloblasts are said, these are large cells with relatively small nucleus. Blasts, the cytoplasm is markedly increased because RNA synthesis is normal, while the nucleus is slowly growing because there's deficient DNA. So the RNA is not being converted to DNA because you need the B12 and folate for that to happen. So we have already described that already. Next slide. So how does macrocytic anemia present, especially B12? So the symptoms for B12, the onset is insidious, means might not be very obvious, it takes time. As you've said, the half-life for B12 is about 1 year. So it also takes time for it to be depleted from the body completely. So you'll have many hematological manifestations. Yeah. So you have the general manifestation of anemia, as you've said already. So anemia, you have dyspnea, you have pallor, you have fatigability, you have leg edema. Yeah, all those symptoms, the tachycardia, headache, dizziness, faintness, all the general manifestations of anemia. Yeah, that's how it presents. You can also present with bleeding tendencies because of thrombocytopenia, and also increased risk of infection because of leukopenia. Remember we said you will have thrombocytopenia, you will have leukopenia, and you also have anemia. So you can have symptoms related to those three. Yeah? That is hematological manifestations. Next slide. You have GI manifestations in the GIT system. Mainly is a beefy processes, a beefy tongue, what you call the red smooth tongue. So when you examine these patients, one thing you notice, as opposed to the microcytic hypochromic anemias, where we say there was atrophic glossitis, we say there was atrophic tongue. That's what we said last time. This one is the beefy glossitis, red, smooth, and fills the tongue. Yeah? Next slide. Yeah. So the other manifestations are neuropsychiatric manifestations in B12 deficiency. So here you have peripheral neuropathy. They present with lower motor neural defects, peripheral neuropathy. So on the legs, on the hands, they are feeling a bit of numbness. They cannot tingling sensations. That's peripheral neuropathy. Yeah? Can present with pyramidal tract affections, what they call spastic paraplegia. Yeah, when it's quite severe. Posterior column can go affecting the posterior column, loss of deep sensation and sensory ataxia. So those are severe B12 deficiencies. B12 deficiencies can cause that. And you have the combination of the two lesions above, number 2 and 3. We call that subacute combined degradation of the spinal cord. So that is the final, like the complete or the complication of B12 deficiency is a severe vitamin B12 deficiency. The patient with dementia, patients with B12 deficiency can come with the symptoms of dementia, optic atrophy, and some can even be psychiatric. So you have psychosis. Although it's rare, it's possible. So these are basically the neuropsychiatric manifestations in patients with B12 deficiency. Next slide. I'm going too fast, please. You can tell me. No, this is not the next slide. Go down, go down. I think there's a wrong one. Go down, go down. Let's go down, go down, go down. Let's go, yeah, go down again a bit. Yes. Now, no, up a bit. Follow it. Talking about follow it. Up, slightly up. Yes. Okay. So folate deficiency, we've talked about B12 deficiency. Yeah? Folate deficiency is the other cause of megaloblastic anemia. Where do you get folate? You get folate from fresh green vegetables, nuts, yeast. Cooking destroys folate in food. So we advise patients or even ourselves not to overcook our sukuma wiki, our spinach, because when you do that, then you destroy the folate that's found in those green, fresh vegetables. This includes spinach, sukuma wiki, and of course, we've said nuts and yeast. The minimum daily requirement is about 100 to 200 micrograms. That's very little. It's absorbed chiefly in the jejunum. The absorption of folate, unlike B12, is normally a passive process and does not require any transport media. It's absorbed as folate. Yeah, what we call monoglutamate. So folate is in the food is absorbed as polyglutamate, when it goes to the GI systems, it's divided into smaller components, what we call the monoglutamates. The monoglutamates are now absorbed, but absorbed in a passive manner. They not require anything to absorb. So storage is about 10 milligrams, again, mainly in the liver, just like for the B12. The storage for B12 is only sufficient for 4 months, yeah, as opposed to B12, which we said was almost 1 year, yeah. For folate is 4 months. The consequence of this is that B12, folate is the commonest cause of macrocytic anemia. When you bind it, the fact that most of us overcook our vegetables, our sukuma wiki, we rarely eat salads, we don't eat fresh vegetables. Most Africans end up having folate deficiency. That's why for pregnant mothers, we normally supplement them with folate, because we know that most likely where they're coming from the rural areas, they are overcooking their vegetables, so they do not have folate. And the children are going to suffer from neural defects because of lack of folate from the mother, yeah? That's the main reason, yeah? So again, the function is the same as B12, yeah? Essential for nucleic acid synthesis, DNA, yeah, as we said. Its deficiency leads to nuclear maturation defects of blood cells and megaloblastic erythropoiesis, and of course, apart from that, it also affects the neural tube defects. So apart from megaloblastic anemia, neural tube defects. Next slide. Next slide. So what causes folate deficiency? Again, poor intake. We do not eat enough, particularly in children, infancy, old age, poor socioeconomic status, because there's no vegetables to eat. Yeah, people eat jahe or beans because they're easily available. Yeah, and forget to take vegetables because they're not available. Yeah, this is like Kampaland where there's no rain, no vegetables. People can or arid areas where they eat meat products and they forget to eat vegetables. In alcohol excess, again, alcohol can cause anything. Poor intake due to anorexia, not being able to eat, as in GI disease, in partial gastrectomy, celiac disease, Crohn's disease in cancer patients. So basically, decreased intake for any reason. Then the next slide. Next slide. You have the increased demand, what they call relative deficiency, because you're eating, yes, but now you have increased demand. There's physiological, where you find in pregnancy, pregnant mothers require more because, of course, of the fetus. Lactation, again, because they're breastfeeding, they require a bit of more folate than in normal situations. Premature children, prematurity, they need that because they are developing, the DNA is developing, the cells are multiplying very fast, yeah. So of course they need a lot of folate. So these are the conditions that physiologically can lead to what we call relative deficiency because of increased demand. You can also have increased demand in pathological conditions, especially in hematological diseases with excess red cell hemolysis, especially like sickle cell disease. Yeah, sickle cell disease, you are destroying the red cells. So when you're destroying them, you also destroy the folate in it. Sorry. So it's I said hematologic conditions like like that. So the next one is, conditions, deficiency, normal intake, and requirement, but there may be decreased absorption. You are not absorbing properly in small bowel disease, in some drugs, pills or anticonvulsants. This prevent absorption. That's what they do. Yeah. So you're not absorbing it properly, or some drugs are preventing from, or decreased utilization. Again, some drugs like especially antifolate drugs like methotrexate, some anticonvulsants, pyrimethamine, trimethoprim. This prevents the patients from utilizing the folates because they bind to the folates. Yeah, they bind the folates. So when they bind to the folate, then it's not able to be used in the system. The next slide. So we've talked about, next slide. Next slide. Good. So we've talked about megaloblastic anemia. Yeah, remember we said that macrocytic anemia is caused by either megaloblastic or non-megaloblastic. So we say the megaloblastic, talking about B12 and folate. And you've said we described those two, yeah, the causes, the deficiencies, and the clinical features of that. So the other one of macrocytosis is without megaloblastic changes. So this one is not affecting the DNA. That's what basically it means. So you have macrocytes, yes. So you have a raised MCV, more than N6 with macrocytosis or the peripheral blood film, but you do not have megaloblasts in the bone marrow. You have basically normal blasts, normal cells. Yeah. In these conditions, the B12 and folate are normal. Yeah. So it's just macrocytes, but bone marrow is normal. Next slide. So which are the causes of this? We have physiological and pathological causes. Physiological, again, in pregnancy, in newborns. So in pregnant mothers, the MCV will be raised. Yeah, you'll find it raised. So it's not an abnormal thing. That's a physiological change. The same thing with the newborns. Newborns, when you do their peripheral blood films or the MCV, when you go to the wards, you'll be checking that. You find that the MCV is normally very high. It's about 100, 101, 105. Yeah, it's because of the high rate of production of those cells. That's why they are big. But it's not. That don't mean that the bone marrow is abnormal or that they are sick. But then you have the pathological causes. Of course, these are they accompany this, the underlying causes that cause macrocytic anemias. Alcohol excess, liver disease. When people have severe liver disease or liver failure, they'll have macrocytes. In patients with hypothyroidism, they have macrocytes. Some hematological conditions like aplastic anemia, sideroblastic anemia. Yeah, aplastic and sideroblastic also causes microcytic hypochromic anemia, but over a long time, it now causes macrocytes. So those are two conditions. And then some drugs like cytotoxics, example as azathioprine. So these are the conditions that can cause macrocytosis: pregnancy, newborn, children. Those are physiological, pathological, alcohol, liver, hypothyroidism, aplastic anemia, and some drugs. So the next slide.
It's the last one, sir.
That's the last slide.
Mm.
Okay, fine. Go to the slide before folate. I think I mixed it. Up. Go to the slide before folate. It's before folate. Yes, yeah, there. So what are the laboratory investigations? If we suspect a patient has macrocytic anemia, you found that So the first test you do is a total blood count or the complete blood count. Yeah, the complete blood count. The RBCs will be macrocytic normochromic, yeah, anemia. Yeah. So the normochromic means normal color. I mean, not like in microcytic hypochromia. Hypochromia means there's little, the pallor, the central area of pallor is basically within normal. So it means the hemoglobinization is normal. Eh? That's what it means by saying normochromic. Eh? But the size should be big. The WBCs, as we've said, moderate or there's leukopenia. We said that already. Yeah? And then you've said that giant hypersegmented, not pigmented, sorry, these hypersegmented neutrophils. Eh? Hypersegmented neutrophils. Yeah. The platelets, again, thrombocytopenia with giant platelets. That's what we'll find in there. This is total blood count, and this is supposed to be peripheral blood film, by the peripheral blood film. Eh? That's peripheral blood film. The CBC was showing the macrocytes, the macrocytes, and well, the other factors, leukopenia and thrombocytopenia. The next slide. We've said about the bone marrow already. Yeah, we find the megaloblast. So we've said that. I don't think we need to repeat. You have erythroid hyperplasia, maturation defect in the erythropoiesis, giant metamyelocytes, atypical megakaryocytes with as a hypersegmented nuclei. Yeah, I think at your level, it's not very important, but just know that we find megaloblasts and a few of the other abnormal cells in the bone marrow. Yeah, and I've described that. The important one is the megaloblastic, which I've already described. Next slide. So further investigations is, of course, doing if you suspect B12 deficiency, you do B12 levels. Suspect folate deficiency, you do folate levels. The main methods for that, you have the radioisotope dilution immunological assays, what you call shielding tests. There are many ways of basically doing these assays. When you're in the laboratory, then you'll be able to ask them, how do we measure for B12? How do you measure for the folate? Yeah, it's good to exactly know how this is done. In biochemistry, serum iron, ironically, is normally high in B12 and folate deficiency. Yeah, as a form of compensation. Yeah? You'll find the increased serum lactic dehydrogenase, basically reflecting ineffective megaloblastic erythropoiesis. So if you do LDH, you do iron levels, they'll be increased. You talk about immunology, where you do intrinsic factor antibodies. If you are suspecting that there is antibodies against intrinsic factor, you can check for those antibodies. Immunologically, you do the shielding test to confirm a lack of absorption of the B12 due to intrinsic factor deficiency. Good, I think. So if I summarize the investigations, the main investigation is to do a total blood count, obviously. Just tell you about the macrocytes, more than 6. The other parameters will be normal or reduced. The leukocytes, the platelets will be increased or reduced, be normal or reduced. You do a peripheral blood film where you will see what I've just described. You do a bone marrow where you see what I've just described. Then you do other tests. Yeah, the B12 levels, folate levels. If you think about liver disease, do the liver function test. If you think about hypothyroidism, do the T3, T4, and TSH. If you think about alcoholism, look for alcohol levels. If you think about plastic anemia, do a trophine biopsy. Yeah, if you think about the drug problem, do levels of drugs in the blood. So I think that should be the end of the Any clarification for me? Any questions?
And I think if anyone has any question, they can unmute.
Good. Seems the lecture was very clear. Class, what I do, I will send this lecture to you in the right format. So I'll send it to you
No problem.
so that then you can share it with the other class rep, your class. Thank you so much.
Yes,
Have a nice day.
thank you. Same to you.